Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast Network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.
Dr. Travis Brown, what is This Medical Life all about?
This is the pursuit of knowledge as we learn about diseases from the ancient times to the present day. These are the stories of medicine.
Dr. Travis Brown, isn't that a beautiful sound? Doesn't that make you feel rested?
Kind of. It was part of my job to listen to that and actually know it was wrong. So, maybe listening to the heart rate raised my heart rate, going, oh, what's wrong with this one? No, it is. It's an amazing sound. And actually, this is really good. This episode's about hypertension. Mm-hmm. And one of the things that you learn, even, mind you, you don't even have to be in the medical field, the health field, to know about the OBS. What's the OBS? Anyone's watched any documentary, what's the OBS? And the amazing thing about that is what are the OBS? The OBS are what we call vital signs, and this is pulse rate, this is respiratory rate, someone's temperature and blood pressure. But the amazing thing about this is you think it's always been that way. But the OBS have come to us in the last few hundred years. The importance. Now, you as just a layperson can actually look at a person and say, you're unwell. You can tell. What's a good sign if someone looks unwell?
Their skin is a bit paler than it normally is. Mm-hmm. Maybe there's a little bit of perspiration. Yeah. They just don't seem to be with it. It's hard to put a finger on it. They seem a bit distant, a bit off the boil. And
that's often what would have happened thousands of years ago. Someone looks unwell, they're a bit clammy or a bit fever, they feel hot. And even hot is an assessment of temperature, but it was never official. And this is where we get the objective measures. So how unwell is a patient? And if we look at where did these OBS come from, well, the first time we have it is in 1625, which is a person by the name of Santorio who measured temperature using a spirit thermometer. And a spirit thermometer has alcohol in the actual thing instead of mercury. Mm-hmm. And so they used this to start measuring temperatures. And so from there, we get in 1707 a person by the name of Sir John Floyer who published a report monitoring pulse. He would measure it with a pendulum.
Oh, right.
And so that was quite amazing that you would have to have a pendulum when you're measuring the pulse to show how fast. No mention of what happens if the patient had an irregular pulse, but they were starting to do.
Well, they might have had a waltz pulse, 2-3 or a 3-4.
Yes. There you go. So you know your music. So, and then we come to when someone actually added respiratory rate, and this was in 1852. This was Ludwig Taube, who published a report monitoring fever as well as respiratory rate. And so we're starting to get this cobbled together of these are important signs to know about. But it wasn't until the end of the 19th century and the beginning of the 20th century that we would recognise blood pressure being monitored as it was today. And this is because it requires a contraption that had to be invented. Invented, right. Yes. And so the evolution of this is quite interesting. The first person to measure blood pressure was Stephen Hales, and he did it in the 17th century. Now, he was an English scientist and clergyman, but this wasn't on a human. He measured this on a horse.
In December, I used a mare. She was 14 hands high and about 14 years of age, had a fistula of her withers, was neither very lean nor very lusty, having laid open the left crural artery about 3 inches from her belly. I inserted into it a brass pipe whose bore was 1/6 of an inch in diameter. I fixed a glass tube of nearly the same diameter, which was 9 feet in length. Then, untying the ligature of the artery, The blood rose in the tube 8 feet 3 inches perpendicular above the level of the left ventricle of the heart. When it was at its full height, it would rise and fall at after each pulse 2, 3 or 4 inches.
And this was a way that he was measuring blood pressure. So he put it into a clear glass tube above a horse through their artery there and saw it pulsating 8 feet, at 3 inches. Now, that's not a practical way to do it at all, for no clinical application, but effectively what he was doing was he was measuring the pressure in a closed circuit.
Yes.
He may not have known that's what he was doing, but this was a closed circuit and you're just measuring the pressure. There's no use for that at the time, but he was a scientist. The first human blood pressure is actually reported in 1856. Now, this was using a chylograph,
right,
I think, or a kymograph, was Carl Ludwig. He produced this as a measure device of pressure. And the problem is, again, if you want to measure it in humans, well, then this device needs to go into an artery. And so this was a surgeon by the name of Jean Favier who put, during an amputation, this device into an artery. And also, he measured a femoral artery as well as a brachial artery, and he measured them at around 120 millimeters of mercury. And so that's quite amazing. Although the strange thing is, if you were having an amputation, you imagine your blood pressure would be quite a bit higher than that. But
well, at least at first.
yeah, well, that's right. Well, but when you're cutting that off, so it's one of those things. Again, not practical to do, no clinical application, but an important step towards this blood pressure. It was not until the 19th century, the end of the 19th century, when the blood pressure device, what we call the sphygmomanometer, is what is used today. And this is the inflatable cuff with the pump and the glass tube, which is what measures the pressure that you're seeing. And this actually was seen as a new device, a new device to be used on patients. But anything new comes with mixed opinions. And there was even, what's the point of this blood pressure device? What's coming? The British Medical Journal published an opinion on this.
It will pauperise our senses and weaken clinical acuity.
And so that's always the new argument of new devices coming through, is you'll lose your clinical decision-making skills because you're going to rely on that and not look at the patient, which never happens, but it's always the argument. And we then find that there was an influential person by the name of Scipione Rivia Rocchi, and he used this and he taught this device. And he noted that when you put this blood pressure cuff on and slowly deflate it, you see the pulse on the fluid, just like what the Stephen Hales saw. You see that little pulse in the fluid, and you can say, well, this is what they called then the systolic blood pressure. That's the height at which that pressure is being gauged. Mm-hmm. And so that was an important first step. So in 1905, we have Nikolai Korokov, who was a Russian surgeon. He started measuring the blood pressure device with a stethoscope, listening to the brachial artery just in the cubital fossa.
That's where they put that just on the elbow there.
Just on the elbow. And so you're listening to the artery. And so when you actually inflate the tube, you're occluding the blood going through. And when you let it through slowly, you're listening to the pressure when stuff actually starts coming through and it pulsates again. The top part, the first part you listen to, is the systolic pressure. The pressure that you hear or disappears is the diastolic pressure. And so we call these Korokov sounds, even these days.
Right.
And the interesting thing, probably the most interesting thing to me, was there was debate about the usefulness of this. And so they're like, well, what does it mean? What is this pressure? And so that raged for decades. And we've got a good example of this at the time. The example I want to use of this is Franklin Delano Roosevelt, FDR. And he will be someone most people will be familiar with. He was born in 1882. He was born in Hyde Park, New York, and he's the United States' only 4-term president. Now, he was a public servant turned politician, become a Democrat, And at the age of 28 years old, he was elected to the New York Senate. And this was in 1910. The President Wilson appointed him as Assistant Secretary in the Navy. And in 1920, he becomes the Democratic nominee for Vice President. But in 1921, at 39 years old, he is struck down with what they diagnosed as polio.
Oh.
But this is a bit interesting, and it's a debate, it's a discussion for another podcast, because that diagnosis has come into question. But what isn't in question was he lost the ability to walk, and he struggled with this the rest of his life. He was able to walk aided. He required a wheelchair and often crutches. Now, this was hidden from the public because you're a public face, and that didn't want to be disclosed. In 1928, he became the governor of New York, and in 1932, he was elected to the president of the United States. This was the first of the 4 terms. Now, these were extraordinary times. This time over his presidency covered the Great Depression.
Yes, exactly.
Covered World War II. And it's interesting to read about his health, because we know about his real health of that, but there's this president of the United States and politicians that have regular checkups. There's this kabuki theatre that goes on about the politician's health, and his health was always excellent to the public, and yet we know it was completely opposite. And
so that's the sort of thing we expect from authoritarian states these days. We can't trust what they say, but we give the truth.
I was trying to find and say, well, where has anyone, any president or any politician actually said their health is bad today? Oh, he's a little bit depressed today. He's got a bit of a problem. He's a bit down. And I was like, I couldn't find it. There might be out there, but I couldn't find it. But this was the point. The fortunate thing we have is because the president receives the top medical care and reviews, and constantly reviewed. And so in 1937, we know his blood pressure was 162/98.
That's high.
And that was at the age of 55. That's right. This would be hypertensive these days, but back then, what it was. Mm-hmm. 4 years later, his blood pressure was read at 188/105.
Okay.
Now, this was in 1941. He was 59 years old. So they thought this might be an issue. So they recommended phenobarbital, which is a barbiturate, which reduces anxiety but can be addictive, and massages. And so, but again, that's the treatment of the time. In April of 1944, his blood pressure was 230/126.
Okay, that is definitely high.
And his ECG is showing changes consistent with a large heart.
Oh.
And then in November 1944, he's elected to his 4th term as president. His blood pressure at this time is 250/150. And then in January 1945, this is just nearing the end of World War II, his health is in significant decline. He's got a loss of appetite, his weight loss, his hands are shaking uncontrollably. And interesting that this was around the time in February of 1945 when they had the Yalta Conference. And this was a conference between Churchill, Stalin, and Roosevelt about how they're going to pretty much finish off Nazi Germany. And he has a blood pressure of 260/150. He's in heart failure. He has shortness of breath, and he has what we say is orthopnea. So he has breathlessness laying down. His evidence, his poor health is evident to everyone there. And there is Dr. Lord Moran, who uttered his opinion to Winston Churchill at the time.
I give him only a few months to live.
And some even say that this affected the outcome of the Yalta Conference. William Harriman of the American Special Envoy to Europe noted.
At Yalta, I believe Roosevelt didn't have the strength to be quite as stubborn as he'd like to be. I suppose that if FDR had been in better health, he might have held out longer and got his way on a number of detailed points.
And so, in any event, it doesn't actually matter. Stalin reneged on the agreement a little bit way along anyway. And despite all of this, his health was announced as being excellent. And so everyone could see, but that's the announcements. And even his speech to conference about the Yalta conference, he did it sitting down because he was, quote unquote, exhausted as opposed to anything else. And then in April the 12th in 1945, he was sitting for a portrait in Warm Springs, Georgia. And midway through the artist, he complained.
I have a terrific headache.
And a moment later, he collapsed. His cardiologist was called and rushed. His name was Dr. Howard G. Brunnen, and his blood pressure was 190. And he died of a stroke. He was 63 years old. And there's even online, you can see an unfinished portrait of Roosevelt, and that's almost like a death mask of him. And when we look at it, in hindsight, this result almost seems inevitable. He ended up dying of a stroke. And we look at it and go, well, how could this not be seen to come? And that's because we're looking at it through our eyes. Back then, increased blood pressure was seen as a normal part of the aging processing. That's why the diagnosis of essential hypertension was thought, because it was essential. It was part of the aging process. There's no treatment available. So they tried to do something, but it wasn't urgent. It didn't actually matter. And even if they tried anything, it wasn't effective treatment. 3 years later, after Roosevelt's death, President Truman signed the National Heart Act, and this initiated some pivotal studies to identify. But it was still over 20 years later when we started to get the evidence that in 1967, treatment of severe hypertension reduced strokes and congestive heart disease. 1970s, treatment of moderate hypertension did the same. And then we've got 1980s, they showed even treatment of younger patients of hypertension was beneficial. And so this is, I remember seeing in medical school an interesting graph, though. And this was a graph, it was actually by a pharmaceutical company, and it had on the bottom age, and on one side it actually had risk of death. And you can see as you go across, you get older and older. Down the bottom is the blue, and up the top is red, or the top right is red. And you could see that as soon as you're aging, get to a certain age, the risk switches over, becomes more and more likely that you're going to die. Effectively, at the end, the whole point is the bottom left is blue, the top right is red. And the interesting thing about this is we saw the risk of death on the left-hand side just kept on going up. More kept on getting added, heart attack, stroke, everything that's going on that was cause of death. And I remember looking at this graph and thinking, there's actually no safe aging disease. Like, there's no safe aging process here. Effectively, the older you get, the more likely you are to die. Sure, we all accept that. But there's no safe way to do that. And so that's the interesting thing. So what do? Well, we prescribe more medications for people. Okay, you're at this age, you should get this medication. You're at this age, you should get this medication. I worked in a geriatric ward, and you would literally come with 2 or 3 pages of drugs on what patients were on. And the amazing thing about the geriatricians is they would take off a number that they didn't need, which was just incredible because it's almost unheard of in the medical field. And this is where we come back to hypertension and cardiovascular disease. Where are we going with that? What's the most effective way forward for our patients? And it might not mean that more is always better.
No, although if a recent US president would have brandished those numbers saying, I've got the best blood pressure, I've got the biggest blood pressure. No. Anyway, let's chasten ourselves. I am getting a headache now. That's a lot to absorb. We have a guest from Western Australia joining us in a moment. Professor Simon Dimmit is a consultant physician working in general and cardiovascular medicine. He's worked in the United Kingdom and New Zealand. He is Clinical Professor of Medicine at the University of Western Australia and Adjunct Professor, School of Medicine and Public Health at the University of Newcastle. His more than 100 publications include 5 postgraduate textbooks. Recent journal publications address clinical dose and preventative cardiology. He's a national examiner and hospital accreditor with the Royal Australasian College of Physicians and chairs the St John of God Healthcare National Human Research Ethics Committee. He has an interest in evidence-based prescribing and is our guest today on This Medical Life. Welcome.
Thanks very much. Pleasure to be here.
As someone who every day takes a little Reptan 1010 tablet, I'm very keen to hear what happens in this conversation today. And I would like to start by asking you what the current definition of primary hypertension is.
Thank you. Interesting to hear about medication, but a lot of it's lifestyle. But the numbers, well, not controversial, but constantly being reviewed and discussed. But blood pressure is consistently greater than 140 systolic and 90 diastolic are considered significant clinical systemic hypertension, get attention from all clinicians, particularly primary care GPs. But the better criterion, which will come out during some later discussion, I trust, is to observe blood pressures, not treat by numbers so much, encourage healthy lifestyle, but to consider pharmaco or drug therapy if there's any clinical evidence of complications of hypertension, which is analogous to diabetes and its complications. So the common complications of hypertension, again, we'll be talking about, but a stroke, loss of vision, angina, and leg pain with walking, which we call claudication. And all of those disorders are driven substantially by elevated blood pressure. And obviously that brings patients to attention, but is class 1 for requiring active interventions by the patient, family, and their GP.
So looking at the diagnostic criteria for hypertension, what will classify someone as being hypertensive?
So greater than 140/90 is the common definition. In the US, they consider active treatment at 130/85. In physiology and at school, we heard 120/80 was normal, but normal goes down to 100/50. So it's a multi-level answer, but 140/90 unequivocally is accepted by everyone as clinical hypertension.
So now just look at, does it have to be just a once-off? If someone's had blood pressure, you've got the white coat syndrome, someone walking through and they're a bit anxious about it. Is once enough, or is it something that you like to see done repeatedly?
Yeah, this is where the more you look, the more granular, more detail, you can argue different ways. And obviously, if the patient has symptoms of arterial disease, like I've referred to, a lower number would be considered worthy of treatment, for example, the 130/85. But the problem is, as you've clearly outlined, is the variability of blood pressure. It's a vital sign, and physiology affects it. It's meant to go up and down 50 or 70% with activity. Anxiety, as you say, white coat is an example of that in clinics where the blood pressure goes up with fear or anxiety in a clinical setting or with clinicians around. But it's meant to go up with normal exercise, as we see in cardiology exercise tests, up to 180, the top reading, and the lower reading well into the 100s. So it normally moves around an awful lot. And so we've settled increasingly on resting, seated or lying down blood pressure, or preferably in a quiet room for 10 minutes. A nurse sets up an automatic machine and walks away to get some idea of what you might think of as basal blood pressure measurement. Because of all of these more than nuances, because of the enormous variability of blood pressure, it is safer for the clinician to listen for symptoms and look for complications of blood pressure, and certainly then consider drug therapy. And up to that point, occasional elevated blood pressures would still prompt advice about healthy lifestyle.
So looking at, I've always wondered about, is there one value that's more important than the other? Is systolic more important than diastolic? Is there one, if one's above a different level, is that more indicative of hypertension? If diastolic is above that, the level, the 85 or the 90, is that more important than systolic being above the 130 or 140?
Good questions and fascinating considerations. Have always fascinated clinicians, which might be more important. So systolic blood pressure is easier to measure, even with a stethoscope and an external sphygmomanometer, but it's the one that moves around under brain autonomic regulation so much as a reactive thing, hence the term white coat. Systolic blood pressure predicts cardiovascular events, but as blood pressure goes up, cardiovascular events rise exponentially. So there's an increasing incline. So errors there, or the variability, it's hard to get a grip. Whereas diastolic blood pressure is more stable, pretty easily measured now with an automatic device. There were issues about exactly the cut point in auscultation with the stethoscope. And the target diastolic blood pressure, which is not as evidence-based in a prospective randomized trial as you would like, is absolutely clear on treatment in many cross-sectional studies. The diastolic blood pressure has a sweet spot as a kind of J curve or hockey stick shaped curve of 70 to 80. And even mortality, but certainly cardiovascular events, increase lower than 70 and higher than 80 as a herd or population statistical epidemiological prediction. So I'm increasingly advising patients and GPs to stay within that range. And some work suggests that the diastolic's up to 90, a pretty flat curve, but above that, very clearly cardiovascular events and mortality increase. So this is contrary to what you'll see in the guidelines and what pharma has used to, for all good intentions, including marketing and profits, of course. So yes. The systolic has been increasingly concentrated on by colleagues because it's a bit easier to measure that exponential increase in risk. And unfortunately, very often the issue is anxiety or circumstances. So the diastolic, both should be taken account of. And in terms of targeting, which I'm not a great fan of, as I say, there's no specific prospective evidence there. The cross-sectional studies unequivocally suggest that aiming for 70 to 80 is the safest path.
Simon, I'm curious to know, how many of us are there? I outed myself as someone who is taking some medication for blood pressure. What is the prevalence of primary hypertension in the community?
Yes, there was early, very limited data in Pacific communities, first encountered by Europeans, that at any age and right across, they had normal blood pressure around 120/80. But in first world countries where most of the data has been collected, the prevalence, the number of people who have a blood pressure consistently above 140/90 is roughly the age as a percentage, 20% in 20s or a little below that, and rising right across life, 50% in 50s and over 80% in people who are over 80. So it's an easy way to remember. The overall prevalence repeatedly in summaries and reviews of hypertension talks about 1/3 of us having clinical hypertension, but it changes with age, and there's no suggestion that the numbers should be treated any differently with different ages, except clearly events are much more common with age and indeed rise exponentially to about 65. So they're the numbers. Your age as a percentage is your risk of having clinical hypertension.
Mm-hmm. Can I ask, do we know the etiology, the cause of primary hypertension?
Yes. So primary hypertension, of course, distinguishes from specific causes like ischemic kidneys. and hormonal endocrine causes. So primary hypertension is multifactorial: genes, body mass index, degrees of renal impairment, which become near universal after about age 60, and that causes salt retention, which is a huge factor in high blood pressure and why diuretics are the most effective drugs. Systolic blood pressure, in addition, is very influenced by reduced arterial elasticity. The large arteries become more fibrous with age, and plaque develops of lipid and cholesterol that makes them stiffer, which escalates the top reading, the systolic blood pressure, and rather confusingly lowers the diastolic blood pressure in time.
Yeah.
And anxiety is the other factor, which is controversial, treating blood pressures that are elevated because of anxiety, or trying to treat the anxiety maybe with anxiolytic drugs. So multifactorial, and so hard to pin down for the individual patient.
So then just finally, looking at the complications, what are we trying to prevent when we're trying to treat someone with hypertension?
Thanks. The biggie is strokes, small and large artery strokes. The small strokes, or any strokes, contribute substantially to dementia, and maybe more than half the etiology of dementia. And some of the studies are showing that dementia plaque is secondary to ischemic strokes. Reduced vision, particularly in diabetes and with macular disease, so-called, is high blood pressure is a major risk factor, and lowering blood pressure has been shown to reduce that process. Then in terms of cardiac, there's heart failure. Blood pressure is, other than age and perhaps BMI, the biggest predictor of heart failure, and perhaps similarly coronary disease, where blood pressure, less risk factor, and BMI, a bigger risk factor. And the other consequences are ischemic, as we say, reduced blood supply due to arterial disease, damage to the kidneys, and plaque in the lower limb, the leg arteries, which we call peripheral artery disease. So all of those are hastened substantially by elevated blood pressure and can be arrested. So the progression slowed right down, not reversed, by good control of blood pressure.
My goodness, thank you for that setting of the scene, the laying of the foundations. We're going to pause briefly and come back and look at the evidence-based prescribing for this. So I might even take an aspirin and have a lie down, probably against your advice, Simon, and be back in just a moment. Continuing now with Professor Simon Dimmit on This Medical Life. Simon, with more than 5% of acute admissions in hospitals and around 7,000 deaths per year in the US are being due to long-term prescription medications, I'd like to shift the discussion now to this concept of evidence-based prescribing. How do you define this?
I secured a couple of quotes because no one's agreeing
Okay.
here. One is the conscientious, explicit and judicious use of current best evidence in making decisions about the care of individual patients. And another is combining network meta-analysis, these are systematic reviews, with multi-criteria decision analysis to choose among multiple drugs. Now, none of this adds up for the busy clinician because the internet's there, but the judgment of experienced GPs is superb, the intuition often reliable, and all I can recommend is aide-de-memoire tables and so on within view of the busy clinician, and possibly guidelines, but guidelines have become even more controversial than conclusions from the individual clinical trials. But the essence is to use best evidence in the selection of the most effective and appropriate for that patient drugs. And the best evidence base I like with my patients is appropriate clinical monitoring. Now, the anaesthetists and the intensive care doctors can do that with blood pressure and titrate, as we say, move doses around in response to changes in the vital signs in the patient's condition. much more difficult in preventive health, where silence is golden and one assumes the drug is working. But so we come back to the blood pressure numbers repeatedly, and but there are other useful ways of monitoring patients with high blood pressure, and one of the most useful, of course, is the electrocardiogram, where there are subtle changes of high blood pressure in all patients who merit treatment, with the T waves and so on, and twice a year biochemistry, particularly renal function, electrolytes, and other relevant laboratory parameters are essential. So that's evidence on which your treatment is based and by which you change the drug. So it's got a broad coverage there, and is done rather well intuitively, particularly in the primary health setting. But the guidelines are very rubbery, and the targets, as I say, not specifically evidence-based. Hence our discussion today, because there are some simplicities that come out of all the clinical trials. It is the most researched area, arguably, in health and medicine, because of the interest which you foreshadowed going back so many decades. And there is a lot of evidence which leads to what I'm going to suggest, I hope, with your next questions.
Well, looking at it, something that comes up a fair bit is this J curve that we're talking about potentially prescribing maybe higher doses as to try and get a maximum effect for your patient. Now, is that always warranted? Is that advisable in your opinion?
First, do no harm, of course, is an adage all over healthcare, and particularly for doctors. So there's probably nothing in life where we start with the maximum when one's cooking or driving or while seeing friends. You don't pour it at them full on at the beginning, unless you're Robbie Williams or a concert, I suppose. But start low, go slow is the adage. But the real problem with any drug is that most drugs, and certainly in hypertension, all of the drugs are receptor blockers or antagonists, and with all of them, the effect rapidly plateaus. So the incremental benefit diminishes very quickly with dose. The adverse events, on the other hand, continue to increase. They come in later, and then at a steeper part of their curves with higher doses. But some of the adverse events increase exponentially. So this all creates the so-called hockey stick or J curve, where there's a sweet spot at low dose, often very low dose, particularly because the drugs are being taken every day for the long term. And the effects which you're looking for, the incremental reduction each year, reduction in heart failure up to 50%, stroke up to 30%, that happens over years, but the adverse events similarly accumulate, or many of them do. So there are a lot of forces at work to make it prudent with long-term therapy to use actually very low dose. Aspirin was where we first learnt the hard way that this is very much the case.
So then balancing, how would you recommend, because there's so many drugs out there, it's a really hard thing, just go low, go slow. And how do we balance that for GPs? Do you do the ED50 level? Do you start with a minimum dose? What's the practical application for the working GP?
It turns out that pharma, in its wisdom, without disclosing a lot of the trial evidence because it's protected by patent, have, in terms of denominations of doses of most drugs in Australia, and this applies, I think, substantially to almost all antihypertensives, the lowest denomination, drug dose, happens to be very near halfway up the dose response curve, which, as you've alluded, is called ED50. We define it differently to lethal dose 50 and others with ED50, which is a kind of body count reaching a certain threshold like death. And this is becoming increasingly popular, being the halfway point to the maximum possible effect of a drug. So the strict definition is the median population, or in that population you're treating, dose necessary to achieve half the estimated maximum possible drug effect, which is the Emax, of course, and the plateau of the curve. So with paracetamol and metformin, coincidentally, that's around 2 grams. And clinicians rarely get even close to ED50, which is where we've got over 30 publications now around the world pointing out that going below ED50, particularly starting, is safer and often sufficient. And the ED50, for example, of hydrochlorothiazide is around 10 milligrams. That's for the population, but for bigger and smaller patients and different pharmacokinetics, the individual patient's ED50 will be different. But as a starting point, we recommend no higher than ED50. It's 30 milligrams for metoprolol, the median population ED50, and around 3 milligrams for a drug like ramipril. These are the three most effective classes of antihypertensive drugs, and I'm just giving those as examples.
So then looking at, I'm trying to sort of grapple with it, because most patients that walk in through the door, I mean, I remember looking at patients and having 10, 15, 20, drugs that they're just on regularly. Is it one thing to just keep on increasing the dose, or would you add another low level if you need to get control of hypertension in a patient?
The polypill idea to which you're alluding, polypharmacy is universal, particularly in the older patient who's rather vulnerable, of course, to adverse events because of their smaller size and diminishing excretion through the liver and kidneys. So it is juggling balls here in terms of all of the considerations. But the idea of a formulated polypill, and two companies brought such out in hypertension, unfortunately not with the optimal drugs to which I've just referred. But the rationale behind this is that drug combinations are, of course, additive. Dose response, because they're antagonists, is steeper at low doses. So you're getting plenty of titratability and efficacy at smaller doses than you might think, whilst adverse effects of different classes of drugs are not additive. So you get additive drug effects, plenty of sensitivity in the patient as you might adjust doses. The only problem is that the on-target side effect, which is reduction in blood pressure, is in common to all of the antihypertensives. And this is where a lot of the adverse effects are in terms of faints, falls, fatigues, renal impairment, and even strokes and coronaries if you overtreat the blood pressure. So it's a multi-edged sword that the polypill trials in hypertension, which have been published, up to 4 drug combinations, have all been rich in adverse effects. The patients have been incredibly motivated and have completed the studies, but most of my friends wouldn't touch one. So there is a problem with polypharmacy, which is a much bigger discussion.
So then looking at that, if I was to ask you your recommendation, how would managing a patient who comes in with no complications but he is hypertensive, what's the most effective management for that patient then?
Yes, well, the treatment is only urgent if the patient's bleeding or got heart failure or angina. Otherwise, the benefits from blood pressure treatment take years to accumulate. So there is time to start one drug at a time, and the guidelines, particularly the Australian ones with which our colleagues will be most familiar, have not favoured starting drugs together, but busy GPs, when patients start with very high blood pressure, over 160, where treatment looks urgent, but it isn't unless the patient has symptoms of blood pressure or they're actually bleeding, particularly, for example, in the brain, in the less common form of strokes now. So it is take an aspirin and lie down, as you mentioned before.
Yes.
And the patients nevertheless see the numbers and become very worried. There are almost 400, I think, randomized controlled, placebo-controlled, that is, long-term blood pressure trials, none of which have ever lowered with time systolic blood pressure more than just under 20 millimeters of mercury. The main way of getting blood pressure down is temperance and active engagement in the lifestyle measures. I persuade my patients to not gain weight because I think losing weight is a personal choice ultimately in the long run, as is stopping smoking and all these other lifestyle measures which add together to reduce blood pressure the most. So the drugs do less than half and lifestyle does more than half of getting blood pressure down over time. But many patients should be counselled and should be educated to understand that 6 months or so is time enough to optimise the drugs and to avoid rushing in and causing unnecessary side effects, because there usually is not any urgency.
I just want to pick up on that and broaden this out to whether or not there's any general or final advice for GPs that you'd like to share on the treatment and management of patients with hypertension. I think you were in this territory already, but I wonder if there's any last lingering insights.
Thank you. So the main thing, and this is the case also with statins, diabetic control, I think, less data, and with aspirin and antithrombotics, look for the symptomatic patient. Try and establish clinical events having already occurred. So we fairly readily do brain scans to see if there are even small infarcts already present, and the ECG, T-wave flattening, left axis deviation, ST segment depression. If these are present, then drugs are prudent, possibly mandated, if you'll forgive the expression, given our recent COVID experiences. So yes. All of these, that's to say that these are all negotiable. The interventions, which parts of the lifestyle program they take on, all to be taken more seriously. And older patients get greater benefit. They're more vulnerable to the higher doses. So it's small doses all around. And the diuretics, in terms of number needed to treat, the absolute risk reduction rather than the relative risk reduction, which is what the marketeers use, show that thiazide diuretics, where there's most evidence, and small dose of furosemide is an alternative, small doses of beta blockers and a vasodilator, preferably an ACE inhibitor, are the three classes in the triple poly pill, which I hope we'll see more research done on and get more confidence about how little is enough in the long term for patients taking drug treatment continuously.
Well, apart from recommending this particular episode to my GP, I will open up the dictionary and see if I can work out the definition to the word temperance, which you used at some point in our conversation earnestly. Professor Simon Dimmit, thank you so much for joining This Medical Life.
Thanks very much.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts via Twitter. Dr. Travis Brown is at Dr. Travis Brown. That's DR for doctor. And Steve Davis is at Steve Davis. Editing and production is by Tim Whiffen. Design is by Tom Buzenjut. This has been a PathNotes Proprietary Limited production.
Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.